Fluid and Electrolytes Intravenous Therapy. This is Martha Olson from Iowa Lakes Community College. As we look at our exemplars for this unit, we see fluid volume excess and fluid volume deficit. Fluid volume excess can be for a variety of reasons, most often running IV fluids too quickly, or the kidneys are not working right to eliminate the fluids that we are putting in. Fluid volume deficit is diarrhea, vomiting, hemorrhage, loss of fluid from wounds. So we see a variety of patients coming in that are also what we would call dehydrated or fluid volume deficit. As we look at extracellular fluid volume excess, we think of the lungs because the fluid backs up and causes problems with oxygenation in the lungs. We see edema, we see weight gain, problems of those sorts. When we think about extracellular fluid volume deficit, the person's dry and they don't have enough blood volume to make urine output or to allow the cells to be oxygenated and have perfusion. So when we look at the problems that each one of them cause, we see very different settings or scenarios for our patient population. As we get started in this unit, we first of all need to learn the normals. When we look at the physiological processes to maintain fluid and electrolyte balances, they're very complex. They interact and work together. So we know that the volume is the amount. How much blood volume do I have? Is it enough to perfuse? Is it enough to make urine output? And then the concentration is the osmolality or the thickness of that. Inside the cell is called intracellular. That space in between the blood vessel and the cell is called the interstitial space. That interstitial space is where we see edema. When you have extra fluid and a person looks really puffy, it's that space in there that is holding that fluid. The electrolytes are important to know. We need to learn the normals for electrolytes in this class because as you progress on in the program, the abnormals will be more of your focus. So we look at sodium, potassium, calcium, and magnesium ions as our electrolytes. They're charged particles, and so they interact. Hyper is above, and so when we have hyperkalemia, that's a higher than normal level of that electrolyte. When we have hypo, that means it's below, and that can also be problematic. In your list of lab values, these are the normals that you need to start memorizing, putting them on note cards so that you can, identify very easily that is not within normal, that's too high, that's too low. We also add in here the glucose and A1C because they fit very well with those electrolytes. As we look at our fluid balance, we know that there's intake, we have to distribute it, and we also have output. So we'll start out by looking at the intake and absorption. You have to be able to have oral intake or IV intake to keep the body hydrated. We can have problems with absorption if the person has had part of their small intestine or colon removed. Maybe their stomach has been made smaller during gastric bypass surgery. So we think of how can we get fluids in to help that person maintain their fluid and electrolyte balance. TPN or total parenteral nutrition is also a way that we can provide nutrition that bypasses the GI system and it goes right into the bloodstream. The distribution is moving the fluids and electrolytes around. We have to have blood flow, we have to have the heart pumping and perfusing, we have to have enough volume to do it. So there's a lot of factors that play into the distribution part as well. And then the output, the kidneys. Are they working? Are they able to eliminate? Do we have vomiting and diarrhea that's causing the person to be fluid volume deficit because they're losing electrolytes and fluid in abnormal ways? And then the insensible fluid loss is through the skin and lungs. A person breathing faster obviously is going to have a higher level of insensible fluid loss because of that higher rate of breathing. As we look at our principles of fluid balance, we know that with over and under hydration or dehydration, we have normal fluid needs, how much the person takes in on a normal basis, and then what are factors that affect that balance. Perhaps they are on a diuretic and they have a higher rate of urine output. Perhaps they have open wounds or a hemovac and they're losing a lot of fluid that way. So a lot of things regulate fluid balance. We know older adults do not have the thirst sensation that they do when they're younger, and so they perhaps will not drink as much water or fluids throughout the day because they just don't feel thirsty. or they having problems with incontinency and they don't want to be a bother or have problems, so they just quit drinking. As we look at regulation of fluid balance, we know that body fluids are regulated by hormones and the amount of fluid going in and out. Our main organ is the kidneys, and we look at the BUN and creatinine, the blood urea nitrogen and the creatinine levels, as well as specific gravity, to know how well are those kidneys functioning. Are they able to do their job, or is the whole body compensating as the person struggles with kidney failure? The hypothalamus is where our fluid intake for thirst is regulated, and that capability is also looked at with the hormonal balance for the body. Thirst is stimulated by the blood getting thick. When you have a increased osmolality of body fluids, the thirst center identifies that and says we need to drink more. Perhaps we need to conserve and not have as much urine output because the blood is thick, the osmolality is higher. And so when we have decreased blood volume, like after surgery, hypovolemia because of blood loss during surgery, that stimulates angiotensin II, and the arterial baroreceptors are also stimulated, trying to save some volume for the person or the patient. Hemo is blood, so when we look at hemodilution, that's a big pool of volume. And hemoconcentration means it's not very much. The blood is very thick and concentrated. Think of a swimming pool. And when you have an Olympic-sized swimming pool and lots of water, that's hemodilution. If I poured Kool-Aid into that Olympic-sized swimming pool, it wouldn't show up very much because there's so much there. Hemoconcentration would be putting the same amount of Kool-Aid in a little pool in the backyard, and it would look very thick and very concentrated and change that much more rapidly. So as we look at hemodilution, that's from excess fluid, and our electrolytes look abnormally low because you're taking your sample of water out of the Olympic-sized swimming pool. Hemoconcentration, the electrolytes might look abnormally high because when you take the blood to run the test for the electrolytes, you're taking it from a very concentrated type of output. Our normal output but decreased intake is another consideration. Our kidneys are working fine, but the person just is not drinking for a variety of reasons. Perhaps they're NPO for surgery or tests. Perhaps they have had vomiting and diarrhea. You see that in pregnancy with hyperemesis when the woman has a lot of nausea and problems keeping things down due to morning sickness. Remember, the kidneys are renal obligatory, and so our kidneys have to make some output no matter what is going on. Urine will be darker. It'll be a dark amber and have a very high specific gravity. However, when that urine is very concentrated because of dehydration. As we look at another factor that plays into fluid and electrolyte, increased output with increased intake. And so we see hypokalemia, potassium is lost, perhaps in diarrhea. What the patient will need then is replacement of potassium. Output is increased in things like diarrhea. Intake is decreased because of vomiting and diarrhea, and through both of those we lose a lot of electrolytes, and that can be problematic. The electrolytes are very important for things like muscles, including the heart, and so with hypo and hyperkalemia you will see actually a change in the telemetry or the rhythm of that heart, and with extremely high hypokalemia or hyperkalemia you can see people die from that because the heart just cannot contract normally with that electrolyte being so off balance. When our output is less than intake and absorption, we can have problems with fluid volume excess. Our problem with that is either the kidneys are not putting urine out or putting fluid out, or we take a lot of fluid in rapidly. And most of the time in the hospitalized patient, it's because we have the IV running too quickly. It might be a little old lady or gentleman that has some congestive heart failure, and we overload them by running in a fluid challenger of IV fluids at 150 an hour when it's too fast for them. With the PO intake, you can see that with people that sometimes will do contests or races where they see who can drink the most water in 20 minutes, and they actually will die of hyponatremia because they have diluted that sodium down so much because of high intake during a short period of time. Sodium restricted diet for patients that have congestive heart failure, kidney failure, they're retaining fluid because of edema. We can see where we try to work with lowering the sodium in the diet in cases like that. Other regulators of fluid balance are, besides the hypothalamus, the posterior pituitary is where that hormone, antidiuretic hormone, is released. We see that the antidiuretic hormone is just like it sounds, against diuresis. It holds the fluid in. The body keeps the fluid when the posterior pituitary puts that hormone out. The kidneys respond to that and they retain the water. They dilute the body fluids to maintain or retain that normal osmolality. So ADH is very important in this whole process of fluids and what we're doing with those. The other one is aldosterone, and we know that that is made on top of the kidney on that gland called the adrenal cortex. It makes angiotensin II. That's released in response to high plasma potassium levels, and we try to counteract that, to counteract the hypovolemia. So the release of aldosterone is what we consider a volume regulator in the systems. Our regulated enzymes, then, you will learn about this because many of them are related to blood pressure meds. You hear about ACE inhibitors, and many of the processes and pharmacology is related to this process that you see in front of you. We see with a patient with low volume, decreased blood pressure gets to the kidneys, and that releases the renin. So when the kidneys identify they're not getting as much fluid, they make and release renin. Renin then forms and tries to compensate, and so renin makes angiotensin I that becomes angiotensin II, and then the normal volume helps with increased secretion of aldosterone, increased sodium and water to the blood. Age and gender can affect fluid balance. As we see, newborns and older adults are very vulnerable. I could be home as an adult with vomiting and diarrhea for 3 days, and I would tolerate it and probably be okay. When we have these vulnerable populations, we know that they can't tolerate it as long. Small children that get diarrhea get hospitalized, get IV fluids, get help to maintain, because they are a higher percentage of body fluid, normally 80 to 90%. And our older adults, because they have less fluid than younger adults, they have more problems as well with maintaining their fluid balance because of their age. Females have less fluid volume than males because we have more adipose tissue than muscle, and obese people have less fluid because of, again, the adipose tissue. Our distribution of body fluids, intracellular is where the majority of the fluid is in the body. Intracellular is about 40% of your body weight. Extracellular is about 20% of your body weight. And within that extracellular, we have the spaces that are called interstitial, or between the cells and the vessels, and then intravascular, which is your blood vessels. The other places where there's fluid is lymph, and then also we have fluid in the organs. So many places can be affected by off balance of our body fluids or hydration, dehydration. Our water moves with the electrolytes attached in 4 different processes. In the next PowerPoint, we will take off looking at active transport, diffusion, osmosis, and filtration. To finish out part 1 of our PowerPoint, we need to just remember fluid volume deficit and fluid volume excess are both very important processes to understand the pathophysiology underlying that, so we can make the correct type of nursing interventions to correct those deficiencies or excesses in fluids that will affect all of the body processes and homeostasis. This ends part 1 of our PowerPoint.